طبعا أنا باسمكم بدي أرحب في بروفيسور هارولد روبرت who came from Germany. Professor Harold will talk about interdisciplinary control of gastrointestinal symptom. On behalf of you all at Faculty of Nursing and healthcare providers from different settings at Bethlehem, we would like cordially to invite Professor Harold to talk about his lecture. We welcome you. Please, the floor is for you. Thank you.
Marhaban, welcome. First, you see a picture with a patient in the middle. And all about the people around could be you. Mariam, Annie, the doctors in the row, all the students. If the patient is not alone, and he should be not alone. That's the meaning of palliative care, the meaning of palliative medicine. And what's about that medicine with me? I'm a doctor of internal medicine and care about some sub-specialties, oncology, dealing with cancer, and gastroenterology, dealing with organs. And between these, we have symptoms of the gastrointestinal tract, especially by cancer. And we want to look today how it's possible to control them interdisciplinary. That's the very theme of this speech. To my person, what's the most important thing? It's the same as in Palestine society as well. I'm 27 years married. That's my wife. So, not look to titles, look to her. We have two boys, 26 and 25 years old. The same as in your families. How many children do you have? The first question. The same as in Europe as well. But the second one is, what about your fields? I told you. And where are you working? You heard from Mariam, it's Germany, but not only Germany. I'm working around Bonn and Cologne. You know the high church in Germany with the three kings. Yeah, I've seen your chapel. And I'm working as well in two large cities in the south of Europe, in Seville, that's Spain, and that's Hungary, Pécs. So I have three lecture areas in Europe. I'm a knight of the Equestrian Order who is supporting your university, and I'm very proud to support you today with this lecture. We start with a little bit of structure. What does palliative care in our view in Europe, especially Germany, means? And then we do in the first part the care for the mouth. Then we make a break. You have the opportunity to have questions, take your water and everything you like. And then if it is time and interest, we take a second part for the rest of the symptoms. What is palliative care? What is palliative medicine? You look here. I don't know if anybody of you has seen this woolen band. It's given to the bishops of large cities. For example, Cologne. Yeah? A bishop who has some sub-bishops with him. And this bishop promised the Pope, today it's Francis, promised the Pope loyalty. So palliative care means here's a jacket that promises the Pope loyalty, and if you do palliative care, you promise your patients loyalty. And that's the really important thing. You stay with them all the lifetime, up to the end of their life, up to the death. Yeah? The symbol is the meaning of this jacket. And the goal, the primary objective is quality of life. Improve the quality of life. Everything you do, the first question is, does this improve the quality of life of the patient? It's not depending on the lifetime, on the lifespan. You won't, with your methods, extend the lifespan, the lifetime of the patient. But your goal should be the quality of life. So, palliative medicine you look for patients who do not respond to curative treatment anymore, normally. There are patients who can get palliative medicine during curative treatment to improve their symptoms, but normally if they just get it alone, standing alone, they have no chance for cure. And your goal, pain control, control of symptoms, is not only of body symptoms, it's of mental symptoms, it's of social problems, and don't forget, in all religions, you have many religions here, spiritual issues as well. I told you, quality of life is your goal, and the best possible quality of life for patients, and don't forget, you all come from families, for their families is your goal. That's the definition. I don't know if you can see it in the rows very in the behind. 1990 of the World Health Organization, WHO, is written, what is palliative medicine? And now we come to the second part, what is interdisciplinary? So you don't have not only one team, you have many teams, many disciplines, and they have to cooperate. They have to cooperate and find their ways together to the last end and look, can we put these ways together? And that's not only possible without communicating. Just sitting there, reading books, going to internet or Google, it's not possible. You have to communicate with these teams and look if you can find a way for all the subways to the end. And the center of this goal is the patient, the individual patients. So there's a picture of a circus of China. Yeah, the patient, as the first picture you saw in the middle, and all the people around are caring for this patient in an optimal way. That's the goal. Perhaps it's not necessary to have a radiotherapist. Perhaps it's not necessary in the beginning of the treatment hospice care. But normally you do have all a family doctor. Normally you have, if you have a cancer disease, a specialist. Call it oncologist, I don't know, could be gynecologist, gynecologist, as ever you want to tell. Normally these two are the basis of the cooperation of the palliative team. And then others can come and add. It can be a pain treatment ambulance, it can be a palliative care unit. So the nurses who will be trained here in the university can be then there in a special care unit. In Germany we have such special care units next to the nursing units. So the nursing units care for the patients in the basic needs, and the palliative care units, they care for the special needs. So they put together all their knowledges and all their skills to be around the patient's needs. So we have it here, normal care unit, palliative care unit, next to each other, but they have to communicate and look what is necessary, what can they add to them. Some other examples here, cancer aftercare, so the treatment can be done, and you have to look for the future, look here for some other services in the around setting in the ambulatory care, and all these settings need to be combined and communicating. One is missing here. I told you in the beginning it's not only about physical and mental symptoms, the spiritual care. Don't forget the priest or the imam or both. Yeah? Perhaps the family has both in the larger family. So sometimes it's spiritual care from both religions or other religions. I don't want to exclude any of the religions here. Basics. The basic of symptom control is the evaluation. To have really an anamnesis, a diagnosis, to look what are the symptoms, what are the problems. And this is not only by the patient, it's as well if the patient can't answer, if he's too too weak, or he's not in the ability to talk enough about his problems with the whole family. And if you don't do this very properly, and you learn this in your studies here, and you learn this in your practica outside, if you don't do this very properly, everything else is not done properly. This is the basis you have to do. You have to talk to the patient. Look at him, talk at him, look at the surroundings, the books that he's on his table, the pictures of the family he has there. Perhaps he has nothing. There is no picture. You can ask, do you have family members? Where are the children? Where do they live? Are they in Australia? Okay. Why isn't it a picture here? Yeah? So you have to evaluate all the situation, problems of the patient, and then you learn very, very much about him. After that, then you can look for a therapy plan. But first of all, you have to make an evaluation by all the questions you have to ask him. If you make this therapy plan of his physical problems, you have to look about the problems which are in the main area. What is the first one, what's the second one, what's the third one? You can ask him, what's the most important for you? Is it pain? Is it breathing? Is weakness? So you have to prioritize the problems to look what is the main problem for the patient. Might be not the same as for you. You might see the patient and say, oh, you lost so much weight and you're so skinny, and you say, okay, no, it's fine for me, but I have pain on this arm or this leg or something like that. So it's not the same view perhaps for you and for the patient. After this planning, you have to clarify these options and have a way to go and to communicate with the other teams and look if there's a way to control all these symptoms. Perhaps you have a method to be before the problems. Yeah? Perhaps you have a problem in the future, so you can be preventive as well. And after all the methods you've done, you have to review all your methods, your treatment you have done, and to show the team if this what has been done would be correct and would be intense enough or too intense. So attention to the details. Now from the structure problem we come to some examples, and for today the first part is about the mouth. I told you, and these are the common symptoms in the gastrointestinal tract. So in the mouth it's normally a dry mouth syndrome, and the inflammation of the mouth, we call it mucositis. And for the second part, after the pause, it's nausea and vomiting and constipation. The fourth, fifth, and sixth are done later, perhaps in the end of the year or next year if we come back. Oral care. What can be done here? What can be done with interdisciplinarity? So often we have the problem, the people tell, okay, I have problems with swallowing, I have problems with my teeth or something like that, but nobody looks. So don't only listen, don't only ask. The second step is look. No? Go to the patient as nurse, as family, as other patients, and as you as doctors in the first row, of course. Look both. Yeah? Look and say, okay, what about all the parts of the oral cavity? Look to the lips as well in the parts inside. Not only ask, look. It's very difficult because we are shy. Yeah? I don't want to be aggressive and say, okay, open your mouth and I want to look. Yeah? You must ask the patient, is it okay that I can look in your mouth? Yeah? Would you be so kind to open your mouth? Yeah? You have pain, I want to look what's the reason for that. So we have to find a common way, yeah? That you and me as doctor would find a solution that I can check your palate or check your tongue. Yeah? And you will say, okay, I don't want to show it. I come back and ask later, perhaps. But both doctor and nurse have to look. It's not so common that the doctors always do it in the gastrointestinal tract. I have an example, storytelling. I have a colleague in my team who has never looked in the mouth and never palpated an anus. Never in his whole lifetime, in 20 years of being a physician. Because he does not want it. Yeah? So the first of all the thing is you have to do. Otherwise you can't control gastrointestinal tract symptoms. So you have to define objectives. For example, you have problems with bacteria or fungi or viruses, or the most problem is not the infection in my view, the most problem is for the most patients a dry mouth. So to make it wet, to moisturize everything, that's the most of the problems you have to solve. And as I told you, all of the team have to discuss what's the best way. If the one doctor says, I never do, I never look, I never palpate, it's a great problem for the whole team, but the team cannot rely on him. Yeah? He never looks in the mouth. Yeah? He says everything is fine, the patient is fine, I've done everything to the patient, but if you know this team player does never look in the mouth, you have a problem with him. So interdisciplinary means you have to look of all the team members and the weaknesses of the team members as well. Perhaps if he does not do, I have to ask his colleague and say, okay, I know it's a problem for you, perhaps you can look in the mouth or palpate in the anus. So pay attention to the preference of the patient. Well, I told you, not everybody wants to show or to be looked for, and for the doctor as well. And document. What you've not documented, it is not done. That's in Germany the rule. You can over-document, you can write 10 sites for one inspection, of course, but if you don't do, nobody knows on the next day what you've done the day before. Another common picture here in Palestine, perhaps, outside the doors. The mouth. It serves language, communication, touch, kissing, food intake. So you have a long list what you can do with the mouse. Yeah? It has 100 times more palpitation bodies in the mouth than on the back. Yeah? Problems. We call it dry mouth, xerostomia, or halitosis, the smelling is not fine, mucositis, inflammation, infections, especially by fungi, pain, crust formation, and after normal by viruses. Mouth and to the throat. Here's an example, normally by fungi. But it can be something else. So if you have done a diagnosis, if you've done a treatment, it does not help, you have to recheck your diagnosis, and perhaps it's a cytomegaloid infection. So if it does not help, you have to take a diagnosis update and take a probe and make an infectious disease diagnosis, perhaps. Goals. You have to ask, I told you, voluntary opening of the mouth. The patient has to have a pleasant feeling with the oral care, so don't open it roughly. No, it's impossible. He has to do it on itself, and they have to look. Many people are afraid of a doctor or nurse coming and looking with a stick or something like that and looking to the mouth. Normally, you should have a clean, moist, wet, and intact oral mucosa. So if it is painful, there might be something wrong. So the game should be played that the pain is eliminated. And the same, you all know, soft lips. You have sticks to treat dry lips, and the patient likes it as well. So an intensive oral care is one of the main actions that we can offer to dying people. It's not a side treatment. It's not a little you can do. It's much you can do for the people with these things. So ask them the customs they normally do. If they normally have no cleaning of the mouth and you do it 4 times or 5 times a day, it might be too much. And if you go with sticks or something like that here and you have a piercing on it, It might be harmful for them. Yeah? So you have to ask, what's your normal way to clean your mouth? So you have to inspect and look what's normal for them. Recognize and document, I told you, especially defects. The mouth is a very, very private part. You all know. No forced oral care. The third time I mentioned that. Yeah? The people could think it's as a rape or humiliation if you do it with force. And don't think about that's crazy to say that. Go to hospitals with time-consuming care and intensive care, and perhaps people are in an intensive care unit and you do it very quickly, and if you ask them later on what was about the care, and they don't forget that. Yeah? Raping the mouth is a crime. So you take your time and do it very, very time spending for the patients. Ask what they like. Yeah? Yeah? Ask what they desire, what is good for them. Told you some examples here. Panthenol, lips balsam, lip balms, sunflower, olive oil, everything you know, and a good lip care. That's your business card. No? It's not so easy, not to say, okay, but you have to do it. And you do it approximately 2 times a day minimum. The same is for the dry mouth. Yeah? It's not only thirst, it's not only difficulty in speech or swallowing. Yeah? Ragads, coverings. You see these large ragads here on the tongue. People have a decreased saliva secretion by the treatment, perhaps by radiotherapy, by drugs, by the chemotherapy, yeah? By the tumor itself, by side drugs, co-medication, opioids against pains, antidepressants, all of them make the mouth dry. And normal drugs as well, diuretics and so on. Yeah? Some drugs from the palliative medicine do as well. For example, here scopolamine, yeah, for people with breath problems in the last time of their lifespan. And especially fear and anxious people have a dry mouth by their fear. So there are a long list of causes why the dry mouth is there. 2 hours a day, 2 hours a day, it's a large amount of time you need for a very, very, very good day care, and normally you don't have. So optimal would be 2 hours a day for mouth and dental care. Here are some examples you can do for the stimulation of the salivation flow. Oils, I told you, for example, of an aroma lamp. You can take pieces of lemon or orange. You can sour candies. Very, very popular is to take frozen pineapple in the mouth. All you do, and the same is for people who can control their mouth action, is chewing gum and freeze favorite drinks and take these things to optimize their salivation flow. You can do some oral massage for specialists who have some training in it, and some external salivary gland massage if you have some training in that as well. But these frozen pineapple, these aroma lamp are very simple things you can do to the people with salivation flow problems, and just try it. You will see the people have an advantage of it. I don't know if you drink the beer from Germany here in Bethlehem, Frühkölsch from Cologne, but it's one of the options you have to make the mouth wet. Spraying liquids with atomizer may contain orange juice, apple juice, Coke, and even beer. It is one of the preferences of the patient. And I told you in the beginning, ask the people, what is good? What do you smell and like in your mouth very well? Might be sparkling wine as well. My wife would never take the beer. She would take the sparkling wine. And think about moisturizing the room. Yeah? There are some instruments to moisturize the room if the patients have problems. And the normal often seen lemon glycerin sticks are not favorized because glycerin binds water and dries the mouth out. The same is for chamomile and sage. These things you all know. Yeah? Chamomile, sage, lemon sticks are normally not well for these problems. If you don't have anything, take water, rinse the mouth, yeah, keep it wet for the day, sometimes a day. That's better than taking chamomile, sage, or lemon sticks. If you have problems with tough saliva, there are artificial saliva solutions you can preparize by the pharmaceutics. You have some options to buy bonbons for these problems, or even drug preparations with mucin containings in this situation. You can, for coverings and sketch, take simple things you all have, butter and margarine and creams, frozen things to improve the situation. There are mouthwash solutions, yes, for cleansing, especially for the people with additional anti-inflammatory problems. It contains normally salvia-tumol as one of the ingredients, and as you have these prepared mouthwash solution and have some good experiences, you can take it as well. There are some problems with tumor breakdown, and especially if you have a bad smelling from that, from odor formation, you can take some additional tablets with chlorophyll, and some problems with greenish discoloration, of course, but if you have really bad odor formation, you can do some things against that. For patients with infections, then you can do mouthwashes with the things you should avoid in dry mouth situation, yeah? But you should be aware of these problems I told you. And if you have fungal infections, candidiasis, you all know the amphomonal suspension or tablets you can take, or even systemic treatment to treat it. There's some tongue brush, special with a toothbrush, to clean, can buy it in a pharmacy if there is no help with these medication solutions. So you have some especially taken brushes here as well in this situation. Tools. You have a large palette of tools from cotton swabs, plastic pipettes, and so on you can take. But the most important thing, is the spray bottle is atomizer. I told you of some ingredients you can use for the people if they like these in their mouth. Yeah? The liquid settles like a film on the sprayed area. It's very easy to use. And use it slowly. Yeah? Again, approach the mouth from the outside very slowly, and remember the private part situation. So if you have a stomatitis, mucositis, yeah, it is possible that it's moderate and mild, moderate, but it might be very harmful in some chemotherapy induced situations, especially if the immune system is very disturbed after transplantation situations, and it is worsened by a bad dental status, and the people have redness, swelling, yeah, they can't even eat and have pain, and for that not weight loss of some kilos, but cachexia. After that, I told you some ideas of sucking cold ice cubes of pineapple. For example, you can do it preventively in some chemotherapy drugs as well. And we have some ready solutions as Tantum Verde in head and neck irradiation, for example. Therapy, additional, you can do mouthwashes in these situations with itis, with inflammation, I told you. not only water and the things, but in these situations, chamomile and sage, that's a very good idea, and pain treatment. It's important that the people have pain treatment. Locally, that can be by xylocaine ice cubes, or systemically by all the opioids you know, and there's a solution you can combine with locally anesthetics and give it in the mouth as well. Other pain treatments are Novamine sulfone, we call it Novagine, continuously or intermediately, and you all have to know that the opioids, very good, the opioids cause a dry mouth, and some alternative drugs, as Novagine does not. So if you have a problem with a dry mouth syndrome, please use these Novagine and other drugs which are not from the opioid area. For the infections of specific cause as fungi and viruses, you have drugs to treat, and there are very new drugs for the last years. If you have high-dose chemotherapy patients, it's just that you have known for that there's a possible ability to do in these patients. So, pain control is one of the most important things you have to do. The patients can eat, drink, and all the things you have to do additionally and to have to know is about diet. That's important because you all deal with diet, so you can do it with a moist eating, soft eating, that the people are not harmed in the mouth during eating the meals. Oral care is important. Do it minimally 2 days. They are down up to 6 times a day. That's very often. And if you have brushes to clean the teeth and the tongue, please use it, that there's an optimal oral care. Conclusion, you need a care team. We tell this team to communicate, to exchange the knowledge of the patient, and it's a lot of people to do, not of technology, there are not many machines, but the people have to coordinate their goals and their success criteria, and most of the things the people have to do is to ask the people, look for the people, and talk to the people, and we call the notion that the people, ethics to the people have is empathy. Symptom control is a symptom-oriented treatment, is active help for life. So, time for questions. Start with a question in the first row. It's simple. Yeah.
You discussed a lot about mucositis. You discussed a lot about mucositis. What's the evidence base for treatment? Do you do like honey? What really are your practice?
Yeah.
Thank you.
Yeah. So, I'll try it again. So, in my view, especially in mucositis, we do not have very, very good experience with honey. I know you have some experience, but the evidence for that normally is not well. No? You can do it in single cases, I agree totally, but the medical-based evidence is not so bad, not so good. Sorry. So, 5 minutes break for drinking and eating outside. So, the second part, please sit down, calm down. The second part is about hyperemesis and constipation. The second and third important symptom groups in gastroenterologic oncology. You have a long list of diagnostics and therapy in nausea and vomiting. For example, if there's a tumor in the esophagus, you can put a tube or a stent, or you can destroy some tumors by heating, by thermoablation. So I have a long list of therapy options as well. So important is to make a proper diagnosis as physician, and you have an option of therapy. So nausea and vomiting has to be looked for, diagnosed and treated properly in detail if you have a patient with it. And the title of the speech was interdisciplinarity. So it's not about one nurse, not about one physician. You have to build up teams of physicians and nurses together. And one example here, structural example here, is a medical corporation in Europe. We call it a medical care center. So you have the options to treat these symptoms, for example, vomiting, by different disciplines, cross-border, yeah, by a family doctor, as I told you, oncologist, and all the others that could be necessary. And you look, if you look here, there are nurses, there are nutritionists, palliative care nurses as well in this team. So you will be in such a team perhaps as well. In Palestine, in Israel, in Jordan, I don't know where you go, Australia, Canada, somewhere else, these teams are built up. So you have to have some knowledge of the diseases, you have to have the knowledge of cooperating in the teams to treat these disease symptoms properly. The picture you know, yeah, that you will be part in a normal or palliative care unit in a team to treat this patient properly. What's the difference? The difference between nausea and vomiting. Nausea is the sensation of discomfort in the throat or the epigastrium, and with a tendency to vote. You feel to vote, but you don't vomit. You don't vomit. But vomiting is a severe discharge, and you vomit the stomach contents out through the mouth. So here is the difference. You think, you feel, will be, yeah, after the party, yeah, after too much eating, the wrong eating, and here you do. Yeah? Nausea, it will be. Vomiting, it is. And you think it's only the party? No, it's a long list of causes. Yeah? For gastrointestinal causes for nausea and vomiting. Yeah? It can be an obstruction, I told you, a tumor or metastasis. It can be fluid in the abdomen. It can be a narrow passage somewhere in the abdomen. It can be drugs. I told you, for example, the opioids, yeah, who lower the velocity of the system. It can be, on the other hand, metabolic. Yeah, the salts can be lowered. Here, natrium. The renal function can be decreased. Creatinine is increasing. And you have some drugs as well who are possible to make such an emergency situation. So if you go to the patient, ask as well not only the symptoms, ask as well not only the complaints, and ask as well the drugs. So your asking might be life conserving of the patient. If you see, okay, he's drugs from the bisphosphonates or the opiates, please think it could be a side effect of these drugs. Vomiting might be a side effect of these drugs. Yeah? It can be toxic, yeah? There can be poisoning as well, you all know that. It can be intracranial pressure, that could be the cause. It can be fear, we talked about fear in the beginning, and pain can make vomiting as well. Here's an example. Rapid weight loss. There might be hundreds of causes why the passage is narrowed. Yeah? It might be something you don't know. Body casts. Some of you take their hairs and swallow it. And if it is over weeks in the stomach, it can be a cast. And for that, here, the barium does not go around it and through the abdomen, so just hair can be a blocking cause as well. We call it a body cast. So you have infectious diseases, you have even drugs withdrawal symptoms. If you don't take your pain drugs, it can be to the vice versa situation that the people are vomiting from that. So you have not only the normal causes, sometimes you have seldom causes. And because of the very, very, very much opportunities to treat, you have a broad spectrum of drugs, pharmacological targets to treat these situations. Not go in details, but tell you, you have so many drugs, targets, that you have to be very, very properly informed that one of the drugs not work, you have an opportunity to choose another one. Yeah? The important thing for the treatment for nausea and vomiting is that you have a treatment against vomiting to a time schedule. Additionally, plus a requirement dose if you need it. So the optimal treatment in treating vomiting and nausea is the same as you know from the pain treatment. If you treat pain, then you have a time schedule base and additionally requirement base. So basis plus bolus. Yeah? So if you have the same here with the vomiting, so you have drugs as basis, and if it is necessary, additionally bolus treatment as well. You can give these drugs in different ways. You can give it rectal by the anus, you can give it subcutaneous as injections, you can give it intravenous. So you have different ways to give the drugs. The first choice should be look for the specific receptors you want to treat, and if it is not possible to work with this drug, you can change after unsuccessfulness after 24 hours. You know all the same in your life. If you have friendship, you can do it some days, some weeks, and if it does not work, change it. Yeah, of course, the same is in drugs. If it does not work, do it a little bit longer, perhaps a little bit longer more, but in span after 24 hours, you have to change. Yeah? Evaluation after regular time schedule events to look is it effective or not, that's necessary. Yeah? To ask, okay, I prescribed this drug, does it help, does it not help? Yeah? And you can switch if it's possible from subcutaneous, rectal or intravenous to more simple drugs as oral. Yeah? If it's possible, even you have these bands here to press some acupressure points is possible in vomiting treatment. So important, time scheduled, plus bolus application. If it's necessary, initially you do it rectal, subcutaneous, intravenous, and change to oral if it's possible and controlled after 72 hours, and change if it's not successfully. There are some very good first choice drugs and second choice drugs, especially if you have gastrointestinal symptoms. Normally we treat them with MCP, metoclopramide, and if it's not helpful, we have a levopromazine drug here as second choice, and if it's treating more to the vomiting center in the central part of the brain, we treat more with D-menhydrinate and so on. And it's important what you want to treat, what you want to achieve to make this. it's important that you have some interactions between drugs. Paspatin, so metoclopramide and Womex are antagonistic, so you can't combine every drug, but you should be aware that there are some interactions between your antiemetic drugs. To be completely, I'll show you a classification. So you have a gastrointestinal effect class of prokinetics, here MCP, Paspatin. As reserve drug, you have an antibiotic. So if you have a patient who does not respond to prokinetics, there's a reserve drug by the antibiotic schedule, and you have some very, very expensive drug treating the 5-HT3 receptor. We call it the vagus blockage. Then we have anticholinergics, I told you in the beginning, scopolamine. And the last one is very popular, the corticosteroids, cortisone. So you have a large spectrum to treat the gastrointestinal effect. The second is CNS defect, CNS defect. Centrally, I told you before, is here Womex, for example, and some more. I don't want to go into detail, but I'm often asked for the cannabis now. I don't know if it's very popular in Israel and Palestine because it's normally forbidden as antiemetic drug, but for people who do not respond to many of these gastrointestinal or CNS drugs, the people now are taking in Europe the cannabinoids very, very, very often. So if you go to the Netherlands, a third of all the Amsterdam area is planting cannabinoids in their houses. Yeah. So if you are looking for, it's a very, very popular drug, and the people try to get it now in Europe because it's in some cases effective, especially in people with some pain syndromes by spastic pains. But now, in my view, the people are taking it especially in anti-cancer vomiting for severe cases and with very good effects. What can the nurses do? What could you do? Drug giving, controlling the drugs is one of your jobs, of course, but you can do a lot more. You can relax the surrounding, yeah? Create a quiet, relaxed environment. Not be loud, not be hectic, not be quick. Yeah? Relaxation exercises you can do with the patients. Yeah? Yeah? You can talk about pictures in their heads. Yeah? Remember a nice field of flowers. Yeah? Go to heaven with ships and look to all the nice colors in your head. Yeah? Relax them. And these factors will lower vomiting as well. You are the best drug for these patients. Time spending, palliative care, to be there, yeah, is the best drug to treat. One example here is destruction by music. Yeah, you can make painting. Yeah, you made here drums. Everything is possible if you have time and take this time for patients with problems. You could wash and treat the patient as you know by your typical care things, cold or warm, offer hot water bottles, aroma lamp. We talked about this in the beginning, but you see you have a long list. So if you care for your job, you can do something. And specific jobs, you can do some relief measures. Yeah, rinse the mouth. We talked about water in the beginning. Yeah, you can do simulating the breathing, yeah, by simulating the body of the patient. You can open the window, yeah. You can help them to be effective in all their body functions. Yeah. Put not so much food in the room, yeah. They smell all the things together, and that's a very great problem. Put the food in the room if you want to feed them, not before and not after. Food should not be stored in the rooms of the patients. It's one of the greatest problems we do to avoid nausea, for example. Yeah? Offer diet, offer this food the people like. Yeah? What is the food you like more? Yeah? If you always give them fish, if they don't take fish in their normal lifetime, don't take fish every day, of course. It's a simple thing. Nutritional advice is not only for the specialized nutritionists, it's for you as well. Think about what you would like to recommend or your family experience. So to be a nurse is more than to be a nurse just for cleaning and for putting the patients in the bedroom. Yeah? Give them advice for the things they need for their life quality. That's palliative care, I told you. Yeah? Some strong smelling spicy foods. Yeah, I know spicy foods are very popular in some societies, should be avoided in these situations. Yeah? Cold is better tolerated than warm. Yeah? If you like eating warm and the patient has problems, try it a little bit cold. Yeah? Offer enough liquids. It's all depends on liquids. Yeah? It should be more offering liquids than in the earlier times of the life. If they take just a little bit, that's fine. Offer ice cubes. Yeah? It's very, very popular in this situation to offer ice cubes and to suck on this. And guide. Yeah? You are not only the nurse for the patient, you are the nurse for the whole family. Yeah? You come from family situations. You come from family-based societies. Don't forget that. Yeah? So go to the families and say, okay, there's a problem with the vomiting of your father or your mother, and help them and discuss this with them together and make that open. Not the patient is in the bedroom above and the family is sitting and complaining in the kitchen. Yeah? Bring them together. Yeah? Bring them nearer. Yeah? And you between them. Yeah? That's important. The last thing, constipation. What is constipation? Constipation means that you have bowel movements less than 3 times a week. Well, we have often patients who come every day and say, oh, I have a bad constipation. Well, so I ask, how much bowel movements did you have? Less than 3 times in the week is the definition. And what's your goal? Your goal is a passage of little hard stool or not diarrhea, hard stool, yeah, and without problems with, yeah. Also, ask them what is really the truth, and if they tell you that's everyday problem, but they do have bowel movements, you have to look to the type. Yeah, perhaps they have a liquid stool. Yeah, perhaps they have a very hard stool. That's their problem. They don't even know what this definition means for them. Yeah? The causes is a broad list as well. Yeah? From tumor caused, about therapy caused, weakness is the most cause. Yeah? The people are too much in bed. Yeah? The food and liquid intake is irregularly. Yeah? And perhaps they have hemorrhoids as seldom causes, but that's not so unseldom. So you have really a large list of constipation causes to look for if you don't know it very easily. And the same as well, ask them, yeah? How often did you use the toilet? Well, look for them, even palpate if you don't have a solution. Make a rectal examination as nurse, and not say I'm shy, it's ugly and I don't like that. You have to do if you look for constipation. Yeah? Look if the people are drinking enough. Yeah? Look to the tongue, look to the skin, yeah? Dryness, and look if they drink enough. That's a very, very often cause of constipation. The people don't drink enough. Yeah? And there are some certain causes you can't measure because it's measured by the lab, but you should be aware that the mood and depression is one of the very, very often causes that people don't go to the toilet by depression. What can you do? You need a team that cooperates with your femoral doctor, and perhaps there are some specialists, yeah, here in the first row, sitting a specialist. If there's a tumor, perhaps it's operated, perhaps it's lasered by gastroenterologist specialists, perhaps it's radiotherapy treated, so perhaps it's just exercising that the patient comes out of the bed. And nutrition counseling, that's your job. That he is regularly eating, that he's drinking, yeah? That you look that he is not too dry. That's the most important thing you can do. It's not about a specific stool frequency. No? It should be comfortable, painless bowel movement. And don't forget, that's not ugly. That's your job, yeah, to look. If patients complains about constipation, to see if there are hard faces or soft faces in the rectum, or if it's even empty, to look then by the doctor about some other causes. Yeah? To say, no, I never do, is a real mistake. You can treat normally with a combination, and the basis is that you look that they have enough fluid intake, and then you can combine with some drugs. Perhaps a softening drug is very popular as osmotic mechanism. Osmotic softening or stimulating is the second one. I don't go to the whole list, but you have reserved medication. If it does not work, you have a X-ray contrast solution to treat, and very new in the last years, opioid receptor antagonists. So you have a large opportunity to treat the people with obstipation. And don't forget, if you give opioids, you should be obligate in giving laxatives, not forgetting them as a co-medication. If the patient has morphine in large doses, it's impossible to see that they have laxatives on board in a co-medication way. So, don't panic, don't leave the room immediately. You have time for 2 questions. But don't forget, be empathic to your patient and take your time. Take your time for the patients up to the end of the life. Symptom-oriented treatment is active help for life. The last sentence. Oh, that does not show it. We can all be accused for that we cannot cure, you and me, but not for that we have not tried to relieve the suffering and the pain. So be the nurse and palliative nurse team for the patient up to the end of the lifespan. Thank you. So, 2 questions left. Come here.
Thank you. You call me sometimes that to give for nausea something hot, and you second sentence you told us to give cold and
Try cold. Better if you have problems, try cold. Yeah? Yeah? If they normally eat very, very hot and they have constipation, cool it a little bit up, a little bit down, cool it a little bit down. Try. Cold is better. It's impossible to resist. So, second question. So I wish you a good afternoon and a good week. Masalam.